speaker is Dr. Manish Bansal. Can I have the CV slide of Dr. Bansal? And I'll request Dr. Malhotra to introduce Dr. Manish Bansal. Dr. Malhotra, please.
Good morning, everybody. Thanks, Dr. Manoria, for this excellent webinar. Dr. Manish Bansal, I have a pleasant task for introducing him today. He is a Senior Director, Clinical and Preventive Cardiology, Medanta, Gurgaon. He has trained at premier institutes in India and abroad, and the Queensland University in Australia, received several awards and presentations. His areas of interest are ACS, VSD, cardiomyopathies, preclinical atherosclerosis, advanced echo, and he has more than 250 publications in various national and international journals. And is the top 2% scientist in the Elsevier list in the World Science 2020. He is former editor-chief journal of IAE and Indian Heart Journal, and he was a former editorial board member of the JAC and Imaging Cardiovascular Ultrasound. Welcome, Dr. Manish Bansal.
Good morning, everyone. Thank you for this nice introduction, and I thank Professor Manoria for giving me the opportunity to present in this meeting. I'm going to talk about role of echocardiography in the evaluation of pulmonary hypertension, the current status. So echo, as we know, is a very important modality in the evaluation of pulmonary hypertension. Although it has its own challenges and standalone, it is not often sufficient to reach the diagnosis or the desired hemodynamic assessment, but it still plays a very important role, and this is what I'm going to discuss. But before we talk about role of echo, what is pulmonary hypertension and how we define it? Pulmonary hypertension in the simplest terms means elevated pressures within the pulmonary vascular system. It can be elevated anywhere from pulmonary arteries to pulmonary veins. Now, as per the previous definition, pulmonary hypertension was defined if mean PA pressure measured using right heart catheterization was 25 millimeter mercury or more. But then subsequent studies showed that normal individuals have an upper limit of mean pulmonary arterial pressure as 20. And secondly, it was also found that patients who had PA pressure, mean PA pressure in the range of 21 to 25, eventually developed pulmonary hypertension and had poorer outcomes. So based on these two reasons, the definition of pH was changed, and as per the current guidelines, we define pulmonary hypertension if mean PA pressure is more than 20 millimeter of mercury, equal to more than 20 millimeter of mercury. And I need to re-emphasize that this definition is based on right heart catheterization and no other modality. Now, as I said, pulmonary hypertension is defined if mean PA pressure is more than 20 or 20. Now, this elevation in PA pressure can occur at any level within the pulmonary vascular system. Now, depending on where the problem lies, we can categorize pulmonary hypertension into different hemodynamic groups. And this distinction is very important for proper management of these patients. So if the problem is confined to pulmonary arteries or pulmonary capillaries, then this is known as precapillary pulmonary hypertension, which is the typical pulmonary hypertension of idiopathic variety, PAH, IPAH. And it is characterized by elevated pulmonary vascular resistance, which is 2 or more than 2 Wood units with normal wedge pressure. On the other hand, if the problem is mainly in the pulmonary venous system, mostly because of elevated LA pressure, then this is known as post-capillary pulmonary hypertension, and it is characterized by elevated pulmonary capillary wedge pressure, but normal PVR. Now, when both are elevated, then this is known as combined pre-post capillary pulmonary hypertension. And in some individuals, we will find that there is pulmonary hypertension, but both wedge pressure and pulmonary vascular resistance are normal. Now, this may occur in situations where cardiac output is increased, and because of high cardiac output, the pulmonary pressure is elevated, even though filling pressures and pulmonary vascular resistance are normal. Now, apart from hemodynamic categorization of pH, it is also very, very important to classify pH according to the etiology or etiopathology, because this classification is what will determine how we are going to manage the patient. So as per the current recommendations, pH is categorized into 5 groups. Group 1 is the pulmonary arterial hypertension, which I explained in the previous slide, the precapillary hypertension, and the most classical form is idiopathic variety of PAH. But there are other entities, also very important entities, which are included here: connective tissue disease, some heritable PH, drugs and toxins related, HIV, portal hypertension, and Eisenmenger syndrome. So all these are categorized under group 1 PH. Group 2 PH refers to PH which is occurring because of left heart disease, that is mitral stenosis, mitral regurgitation, or left heart failure. Group 3 refers to PH occurring because of lung disease, which may be COPD, ILD, obstructive sleep apnea, or any other form of lung disease. Group 4 refers to PH because of pulmonary embolism. So CTEPH is the typical example. And then group 5 is the mixed variety, where the etiology is multifactorial or unclear. Now, it's very important to remember that of all the 5 groups of pH, group 1 pH, which is pH occurring secondary to left heart disease, is the commonest, accounting for nearly 70% of all patients who have pulmonary hypertension. Roughly 10% are accounted for by lung disease related pH, that is group 3. So 80% constituted by these two, 15% the miscellaneous categories, and therefore the typical forms of pH that we often think of when we use the term PAH, like idiopathic PAH or Eisenmenger or CTEP, they constitute only 7-8% of pulmonary hypertension. So most of the times we are going to be dealing with this or this. Now, echo plays an important role in the evaluation of pH at every step, from initial diagnosis to identification of etiology, hemodynamic assessment, prognosis assessment, and monitoring response to treatment. But I want to emphasize once again that for diagnosing pH per se, echo alone is not sufficient, because the definition of pH is based on mean pulmonary arterial pressure. And even though we have got many formulae for measuring mean PA pressure from echo, none of them is sufficiently reliable for making the diagnosis of pH. So when we use pH, our main goal is to just assess the probability of pH and then evaluate the patient accordingly. We cannot categorically diagnose pH based on echo. So what we need to do, if we have a patient who's got who has got symptoms suggestive of pH, we do echo, we look at the TR jet velocity. Now, most of the guidelines and most of the centers are using TR jet velocity instead of TR gradient or TSV, because conversion to jet velocity to gradient has many fallacies. So it's always encouraged to look at the jet velocity rather than the gradients. So if the jet velocity is more than 3.4, then there's high probability of pulmonary hypertension. We need to evaluate this patient further. If the jet velocity is 2.9 to 3.4, then we need to look at other associated echo abnormalities, which I will come to in the next slide. If we find multiple echo abnormalities, then high probability of pH. If no, then intermediate probability. And if the jet velocity is 2.8 meter per second or less, and no associated echo abnormality, then there's low probability of pH. But if there are other associated abnormalities, then intermediate probability. Now, even though the guidelines recommend jet velocity, we still keep on using TR jet gradient. And that's why I mentioned gradient also, just to give us the perspective that 3.4 meter per second jet velocity would correspond to TR gradient around 46, and 2.8 means around 31. So if we have a patient whose TR gradient is more than 45, then high probability that this patient has pH. But if less than 45, then we need to look at other echo abnormalities. So what are the other echo abnormalities that we need to look at? We need to look at right ventricle, pulmonary artery, and IVC and RA. So if RV is dilated relative to LV, then this will be considered as one abnormal finding. For pulmonary artery, we can look at PR gradient, we can look at pulmonary artery size, or we can look at RVOT acceleration time. Acceleration time is a measure of the elevation of pulmonary pressure. If acceleration time is short, like this very steep upstroke, then it indicates that pulmonary hypertension is present, or if there is mid-systolic notching, as we can see here. This will also indicate pulmonary hypertension. And for IVC, we need to look at IVC size, collapsibility, and RA area. So if we find abnormalities in at least two of the three categories, so either RV, pulmonary artery, or IVC RA level, at two sites, if we find abnormalities, then they are considered significant. Okay. So we have come to this point now that the patient came to us, we assessed initially using symptoms, did some initial workup, echo has been done. Now, if echo shows low probability of pulmonary hypertension, then we will have to find alternative diagnosis for the patient's symptoms. But if there is intermediate or high probability of PH based on the algorithm which I showed in the previous slides, then we need to look further. So if the patient has features which raise suspicion of lung disease, then we need to perform tests like pulmonary function test, ABG, CT chest, sleep study, etc. On the other hand, if there is suspicion of some cardiac disease, then we need to look at echo more carefully and we may have to do TE also. However, if there is no evidence of underlying lung or cardiac disease, then we need to look at other causes. We will have to work the patient up for CTAF. We need to look at connective tissue diseases, so ANA, ENA, Epla syndrome workup, hepatitis serology, HIV serology, all of this is needed. And when no cause is found, then we should be doing genetic testing also, because there are some heritable causes of PH which often go unnoticed or undiagnosed. So this is the basic approach how we evaluate a patient with suspected pulmonary hypertension. I will show some examples to explain this further, but these examples will show that when we find elevated PA pressure in echo, it doesn't mean that we have to go and do right heart catheterization in every patient, or we have to evaluate the patient for idiopathic pulmonary arterial hypertension. In many of these cases, the echo itself will give us the clue to the diagnosis. So here we have an example. This is a patient. TR gradient is quite, TR jet velocity 3.7, gradient 54, IVC is full. Now this patient was a 45-year-old gentleman, known case of severe LV systolic dysfunction. He had very poor LV, very high filling pressure on the left side. So he had typical group 2 pulmonary hypertension. We don't need to do any further workup for PH. Another patient, typical rheumatic heart disease, severe MS. We know that the cause of PH in this particular patient is mitral stenosis. Now, in some cases, when even after treating mitral stenosis, if severe pulmonary hypertension persists, we may have to evaluate the patient further, but usually that assessment is not needed. Another example, so 56-year-old lady, progressive breathlessness, there was no comorbidity, TR gradient is elevated, and these are her echo images. As we can see, RARV dilated mildly, there is mild to moderate TR, left side looks okay. So now in this patient, we did T and we found that she had sinus venosus ASD with PAPVC, which was the cause of her RARV dilatation and pulmonary hypertension. So clue to this diagnosis in this particular patient was RARV dilatation and pulmonary pressure, which was not that elevated. Yet another patient. So this is 44-year-old gentleman, known case of chronic liver disease, admitted for liver transplant workup, significantly elevated TR velocity, jet gradient, and these are other echo images. So as we can see here, left side looks normal, RARV dilated. There is pulmonary hypertension, as we can see, very steep upstroke of the RV outflow and mid-systolic notching, IVC is dilated. But the left side was absolutely normal. There was no valvular heart disease and LV filling pressure was also normal. So we made a diagnosis of presumptive diagnosis of portal pulmonary hypertension. The patient was evaluated further. Right heart cath was done, which showed mean PA pressure 20, pulmonary vascular resistance of 6 good units, wedge pressure was absolutely normal. So this confirmed our diagnosis of portopulmonary hypertension. CTAF was also ruled out by doing CTPA. This is a typical example of CTAF. So in this patient, there was severe PH, and when CT pulmonary angio was done, it showed significant bilateral pulmonary emboli. Another example, So here in this patient, the presentation was acute, but when we did echo, we found there was significant RARV dilatation, RV systolic dysfunction, pulmonary artery hugely dilated, and large thrombus in the right pulmonary artery, as left side also. So this much dilatation of RA-RV and this severe RV systolic dysfunction indicates chronic pulmonary embolism. So even though he had presented with acute pulmonary embolism, the diagnosis actually was CTEP associated with acute worsening, acute pulmonary embolism. Another example, so in this patient, 35-year-old lady, progressive restlessness, there was no comorbidity. As you can see, TR jet velocity is very high, gradient 122 millimeter mercury. Again, left side looks normal, RARV dilated, there is severe TR and high TR velocity. So this patient was evaluated further. T was done, no intracardiac shunt was found, lung disease workup was normal, CTPA was normal, blood tests were all normal, gene test was not done, right heart catheterization was done, which confirmed severe PH. So after excluding all the major possible causes, we made a diagnosis of idiopathic PH. Another example which I came across last year, 83-year-old gentleman, hypertension, diabetes. He had undergone CA, BG, and AVR around 15 years ago. Tissue valve was implanted and 2 grafts. So he presented with progressive dyspnea for 1.5 years, evaluated at some other center where SPECT imaging, myocardial SPECT imaging was done. No perfusion defect was found. Echo showed severe PH. But because he was very symptomatic, they did CAG also. The CAG showed native TVD with patent both grafts. His symptoms worsened. He developed bilateral fluid effusion, which was tapped twice. Transitive fluid was drained, suggestive of fluid effusion due to right heart failure. Now, with this background, he came to us. These are his echo images. As we can see here, LV systolic function is normal. There is bilateral enlargement. GLS is also near normal. Aortic valve, the prosthetic valve was almost normal with gradients slightly elevated, mild AR, definitely not sufficient to explain the degree of pulmonary hypertension that he was having. But he had advanced LV diastolic dysfunction, grade 3 diastolic dysfunction. As we can see here, E over E prime was 20. E prime velocities were significantly reduced on both sides. And he, of course, had severe PH with TR jet velocity 4.3 meter per second with jet gradient of 75 millimeter mercury. So we evaluated him further. CTPA was done, didn't show any pulmonary embolism. EFT showed moderate airway obstruction, not sufficient to explain his pulmonary hypertension. And because he had significant LV diastolic dysfunction, we evaluated him for amyloidosis also. So serum free light chain assay was normal, MRI was done, didn't show any myocardial disease. So basically his diagnosis was not clear. So eventually we did cath. Now, as we can see here, his wedge pressure was 14 and PVR is 3 Wood units. If you go by the guidelines, then this would be categorized as pre-capillary pulmonary hypertension. We need to remember that this patient was on high dose of diuretics, and despite this, his wedge pressure was 14, which means it was actually elevated. And PVR 3 Wood units is just above the cutoff value, which is not high enough to explain this severe PH due to idiopathic pulmonary hypertension. So our final diagnosis was combined pre-post capillary hypertension, predominantly group 2 hypertension due to HFpEF. He was already on PH therapies, which were continued, but then we added ARNI also. Diuretics he was already taking. And he came for follow-up 2 months later when he was feeling little better. After that, we are yet to see him again. So basically, all these examples show how we need to evaluate the patient for pulmonary hypertension. Whenever we find elevated pulmonary pressures during echo, we need to remember that 80 to 85% of the time it's going to be because of heart disease, left heart disease, or lung disease. Other etiologies are less common, but when we have ruled out left heart disease or lung disease, then we need to look at other pathologies for which we have to do CTD workup. So ANA, ENA, hepatitis serology, HIV serology. We need to do pulmonary function test. We may have to do CT chest, CT pulmonary angio. And if the cause is not identified, then we do right heart catheterization to characterize the pH hemodynamically. And if we diagnose or suspect idiopathic pH, again we have to do cardiac catheterization, because before we initiate pH-based therapies, it's very, very important to document mean peer pressure and PVR, because pH-based therapies have main role in group 1 pH only. In other conditions, they may actually worsen the outcomes. We often tend to use pH therapies in patients with COPD or even left heart disease, but there they may cause more problem than benefit. So we have to be very careful about that. And when we are doing right heart cath in idiopathic pH, it also allows us to do vasodilatory testing, because if the testing shows response to vasodilators, then these patients are candidates for treatment with calcium channel blockers. Now, once we have done the evaluation, all of these tests that we have done will also help us assess the prognosis of the patient. There are various algorithms described for this, which include clinical parameters, 6-minute walk distance, biomarkers, echo, and catheterization and MRI data if MRI has been performed. But one point which I would like to emphasize here is that as far as echo is concerned, PA pressure has no relationship with prognosis of the patient. What determines prognosis are RA area, RV systolic function assessed in the form of ratio of TEPSA to pulmonary artery systolic pressures. This is also known as RV-PA coupling, and pericardial effusion. And these are the three parameters which are used for monitoring also of a patient who is on pH-based therapies. We often tend to look at PASP for following of patient, but actually that is not important for prognosis and also not important for monitoring. What matters are these three parameters that we need to be looking at. A simplified prognostic algorithm has also been described, which does not include echo. It only includes functional class, 6-minute walk distance, and BNP or NT-proBNP level. We may use this also if we don't have access to a reliable echo. Once we have diagnosed pH and categorized into these 5 groups, then the patient can be treated according to the etiology that has been found. So as I mentioned, pH is dedicated pH therapies are useful only in group 1 pH, along with CCB if the patient responds to vasodilatory testing. Lung transplant is, of course, the final answer. In case of group 2 pH, treatment is mainly the treatment of left heart disease. Very rarely we may use pH-based therapies only if we find that the pulmonary vascular resistance is very high, more than 5 Wood units, not otherwise. Even then, the role is very, very doubtful. For lung disease, again, the treatment of lung disease, the treatment of pulmonary hypertension also, role of PAH therapies or drugs is very limited. In CTEPH, the treatment of choice is pulmonary and arterectomy. Any patient who's got CTEPH and has pulmonary anatomy suitable for pulmonary endarterectomy, then such a patient should be subjected to pulmonary thromboendarterectomy rather than delaying this while treating the patient with medical management. In some patients, interventional approach like balloon pulmonary artery dilatation may also be tried. And lastly, for mixed variety, the treatment will depend on the etiology that we are dealing with. And in the end, as I mentioned, for monitoring response to treatment, we need to look at the symptoms of the patient, 6-minute walk distance, biomarkers, and if we are using echo, then we should be looking at RA size, pericardial effusion, and RV function as assessed using a ratio of TEPSA to PASP. Thank you so much.
Thank you, Dr. Manish. I am your Dr. Sajid Ansari. Nice to see you
Yeah, good morning.
and to listen your wonderful lectures as usual. You give wonderful insight regarding pulmonary hypertension. My one small question to you, in your algorithm while doing your masterpiece of echo, where you are putting strain imaging, RB and RA strain, are you doing routinely any correlation with the strain and pulmonary hypertension?
So, you see, as I mentioned that RV systolic function is an important prognostic marker in pH and a determinant and a marker for monitoring response to treatment also. Now, the guidelines recommend TAPSE by PSP as the preferred parameter. But we know that RV strain, when available, can give us incremental information. Although the data is limited and therefore it's not widely recommended. If we have the access to RV strain assessment and if we have necessary expertise, we can use that also in addition to the other parameters, not as a substitute for other parameters.
What is your take-home message? Because you are working in an institute. Any your concern and your recommendation?
So my recommendation would be that if we come across a patient with pulmonary hypertension and we find that RA-RV are dilated, left side of the heart appears relatively normal and there is no apparent lung disease, then always rule out sinus venosus ASD or ASD
That is good. Yeah.
per se. That is one thing which we come across every month. Every month, we see a patient who's been on treatment, various treatments, and then turns out to be having sinus venosus ASD. So that is a point I would like to mention. And again, we'll re-emphasize that 85% times PH is because of left heart disease or lung disease. Other etiologies are much less common.
Dr.
Thank you,
Manish,
Ravi.
the
Yeah.
type 1
Sorry.
pulmonary artery hypertension, which is
Yeah.
the drug of choice which you start first, or you start multiple drugs together, because there is large number of drugs for treating type 1 or the primary pulmonary artery hypertension.
So now in type 1, group 1 pulmonary hypertension, first point is that we need to do right heart catheterization. We should not start drugs without doing right heart cath. In fact, we should be doing right heart cath more often in patients with PH than we currently do, because it gives us very valuable insights into the hemodynamics. Now, once we have confirmed that the patient has significant PH, then the current recommendation is to use two drugs. And that is one from ambrisentan macitentan group, that is the endothelin receptor antagonist. And the second one will be PDE5 inhibitor like tadalafil or sildenafil. So I personally tend to use ambrisentan macitentan, one of these two, plus tadalafil. Then, if the patient continues to remain symptomatic, we can add prostaglandin, which is currently available, Selexipag in India. In CTEF, Riociguat is the other option that can be used.
Thank you.
Dr. Manish, why there is variation in the RV strain values with different machines? And what is the magnitude of variation?
So variation will depend on imaging, and the tracking. In fact, and vendor differences are also there, but vendor differences have been minimized. The main issue comes because of how we have taken the image. It is recommended that we should be using RV focused four chamber imaging, not the common four chamber view. And then tracking also needs to be verified.
Is there any ethnic differences in the RV strain value?
Sorry, sir?
Is there any ethnic differences in the RV strain value?
Ethnic differences are there, definitely there. And multi-ethnic study has been published by the American Society of Echo, the WASE study, WASE, in which they have defined normal strain values, in fact, normal values of all the echo parameters for multiple ethnicities, including Indians.
There's one question in the chat box. Do echo parameters of RA size oblique RV strain vary in elderly and young patients?
So RV strain decreases with age because of a variety of reasons, maybe pathological, maybe physiological, but RV strain decreases. RA size may or may not change. In a normal healthy individuals, RA size will not be increased in an elderly patient.
So with this, we finish this session. Thank you very much, Dr. Manish Bansal, for the wonderful talk.